Okay, hi guys, good evening, all of you. So, orbit and trauma quiz we'll discuss, and also we'll discuss at the end of the session that other question that I put yesterday, the clinical case challenge. So, that also we'll discuss. Okay. So, question number one, pleomorphic adenoma of lacrimal gland. See, pleomorphic adenoma of lacrimal gland is the most common lacrimal gland tumor. Okay, and suppose it occurs. See, your lacrimal gland is located here in the superior temporal portion of your orbit, right? So, when there is a tumor here, it's going to push the eyeball down and in. So the question is about different types of eccentric proptosis, which direction. So down and out proptosis, sorry, down and in proptosis. So lacrimal gland tumor, any tumor, lacrimal gland mass would cause a down and in proptosis. So in this case, pleomorphic adenoma was a question. Next question, pseudo enophthalmos is seen in. See, pseudo enophthalmos is sunken eyeball. Okay, so the eyeball is sunken. Thyroid eye disease, option A, there is proptosis, exactly opposite. Option B, thysis bulbi. Now, thysis bulbi, let's come back to option B. Okay, option C, lacrimal gland tumor. Just now we saw there is a proptosis, a down and in proptosis. There is no way enophthalmos, and that too pseudo enophthalmos, no. Neuroblastoma. See, neuroblastoma, again, it's going to send metastasis to the orbital metastasis because of neuroblastoma, and again it causes proptosis. So, pseudo enophthalmos is seen in thysis bulbi. So, it's not exactly enophthalmos. It's because of the shrunken eyeball. The eyeball itself, the globe itself is shrunken and disorganized. Because of that, there is definitely there is an enophthalmos, and that is a pseudo enophthalmos, okay, due to thysis bulbi. Okay, question number 3, retarded descent of the upper lid on down gaze. So this is just a play with words. So lid lag on down gaze. If I simply ask you lid lag on down gaze, I know all of you will answer. It is what is the sign called? Kocher sign, Dalrymple, von Graffe, and Enroth sign. You know, lid lag on down gaze is von Graffe sign. So that is what it is, retarded descent of the upper lid on down gaze. Now what is Kocher sign? Kocher sign is a wide stare that you give in thyroid eye disease. That is Kocher sign. Enroth sign is the upper lid puffiness that is there in Graves' ophthalmopathy or your thyroid eye disease. And what's the other one? Dalrymple sign. Dalrymple sign is the upper lid retraction. Okay, so that is the most common sign of thyroid eye disease, whereas the question that I've asked you, von Graffe sign is the most specific sign of thyroid eye disease. Okay, now next one, the first eye movement to be lost in cavernous sinus thrombosis. So the underlying concept to this is, why is the eye movement lost? Because of nerve palsy. Yes, so which nerve is affected first in cavernous sinus thrombosis? It is your centrally located abducens nerve, or your sixth nerve. And what muscle does your sixth nerve supply? LR6. So LR means lateral rectus. Lateral rectus takes your eye out, abduction. So abduction movement would be lost when that particular site cavernous sinus thrombosis occurs, and when it becomes a bilateral cavernous sinus thrombosis, contralaterally also the first nerve to be affected would be that side, abducens, so contralateral abduction. So always the first movement to be affected would be abduction. Okay, so that is a very straightforward question and answer. In fact, it's a previously asked question also, and cavernous sinus anatomy, cavernous sinus thrombosis, important from all points of view, from anatomy point of view, from ophthal point of view, from ENT point of view, and probably even from neurology. Yeah. Now, which of the following structures is a landmark to define preseptal and orbital cellulitis? See, you have this orbital septum which runs from the superior orbital rim to the tarsal plate. Okay, orbital septum. So it is like a curtain which is the landmark between preseptal, anterior to that septum, and a deeper ominous involvement, your orbital cellulitis, which is an ophthalmic emergency. Okay, so that is orbital septum. Regarding option A, LPS aponeurosis. Guys, LPS aponeurosis, what MCQ they can ask you is, LPS aponeurosis is important because it divides your lacrimal gland into two lobes. Okay, it's in fact a previous asked question also, FMG question, very very important. LPS aponeurosis divides your lacrimal gland. Where is your lacrimal gland situated? In the roof. Okay, superior-temporal part of the orbit, but with respect to the roof. And your LPS aponeurosis divides it into a superficial palpebral lobe and a deeper orbital lobe, your main lacrimal gland. Okay, so anytime you have to take a biopsy of the lacrimal gland, let's say for Sjogren's syndrome or something, always do a orbitotomy and go to the deeper orbital lobe and take the biopsy. Okay, regarding option B, Whitnall's ligament. See, Whitnall's ligament is at fulcrum where your horizontal LPS tab tak it is horizontal and then it becomes vertical, hai na? So that fulcrum, so Whitnall's ligament runs here, okay, just beneath your superior orbital rim. That is Whitnall's ligament. Now capsulopalpebral fascia is formed by your inferior rectus and your inferior oblique muscles. It's similar to your kind of like your LPS, so to say. Okay, then unresponsive cases of orbital mucormycosis may require, see, mucormycosis of the orbit is life threatening, so you need to do something about it, and they've also said it's unresponsive. So unresponsive means you have to do that radical surgery, exenteration, just clean out the orbit, remove all the orbital contents. That is exenteration. It's like, you know, like your Terminator, no? Exenteration is you remove all the orbital contents to save the life of the patient. We are not worried about the vision of the patient. We are not worried about saving the eye or the eyeball or the cosmos of the patient. We are worried about the life of the patient, orbital mucormycosis, because if it spreads to the brain, then, you know, mortality is very high. So exenteration. Now Vosch's ring is a result of, now what is Vosch's ring, guys? Vosch's ring is a brown ring you see on the anterior lens capsule because of the blunt trauma. So because of the blunt trauma, the myotic pupil goes and hits, you know, like a rubber stamp, it goes and hits on the anterior lens capsule. So it is a result of blunt injury. Yeah, it is a result of blunt injury. Some of you who have marked posterior vitreous detachment, guys, posterior vitreous detachment results in a clinical finding called as Weiss ring, or Weiss ring as we call it. That is, it's a clinical finding. Okay, so that is Weiss ring and posterior vitreous detachment. Okay, now scleral rupture is suspected after trauma. Which of the following is not a feature? See, soft eyeball, yes, it is a feature, because when there is a scleral rupture, the intraocular fluids, either the aqueous or the vitreous, comes out. So the eyeball loses its turgescence. So, you know, it becomes soft. Decreased IOP, yes, there is definitely decreased IOP. That is why the eyeball is soft. So option A is true, option B is true. Positive Seidels test, when anything is leaking, I've told you already, when anything aqueous is leaking, there's a wound leak, we use Seidels test. We use topical fluorescein, apply it there, keep looking under cobalt blue filter. As the fluid is coming out, is oozing out, the dye keeps getting diluted. As this dye gets diluted, it becomes brighter and brighter. That is its property. Okay, that property is called as quenching. So that is Seidels test. Yes, Abid. Hey, Abid, nice to see you. Yes, it could be vitreous loss or even aqueous loss. Anything. Intraocular fluid, when it is lost, becomes soft. Blepharochalasis. Yeah, blepharochalasis has got nothing to do with scleral rupture. Okay, blepharochalasis is your lid skin, excess lid skin which is hanging. That is blepharochalasis. Okay, all right. Which of the following is the best to localize intraocular foreign bodies? See, intraocular foreign bodies, the most common intraocular foreign body is iron. Okay, iron or iron. Iron foreign body is the most common. So CT. Yes, so it cannot be MRI. No, when you have iron, it cannot be MRI. It's CT. And very rarely you can use MRI. You can use MRI when you suspect a vegetative foreign body, organic matter foreign body, then probably MRI is. But given investigation of choice for an intraocular foreign body, or like they've, you know, worded it like best to localize intraocular foreign body, then it would be CT. Good evening, Vikash. Good evening, beta. Okay, and ERG doesn't localize. ERG is only to find out if suppose there is an iron foreign body, we want to know if there's any toxicity because of the foreign body. Because not all intraocular foreign bodies will will need to be removed, because removal itself causes problems. And what does our oath say? You don't cause harm. Even if you're not able to help the patient, at least don't cause more harm. So by in the name of removing the foreign body, if you're going to cause a retinal tear or detachment, then it's not wise, no? So you just let it stay, the foreign body stay, and just monitor for toxicity. How will you monitor? By electroretinogram, ERG. Yeah. Okay, following blunt trauma, a patient developed a large iridodialysis. His symptoms may include, so when you have a large iridodialysis, it's a huge opening, right? So through that opening, you have a lot of light getting inside. So patient can have glare, or maybe if the examiner wants to use the word photophobia, maybe, but it's actually glare. So let's see what is here. And also light going through the pupil, the normal pupil, and also through this extra hole of iridodialysis. So that will result in two images, and two images when the patient sees through that eye. Even if you close the other eye and the patient is seeing only through that eye, uniocular, still there is diplopia. So uniocular diplopia. So option a, binocular diplopia. Binocular diplopia is only in squint. So this is monocular diplopia. So option B, yes. Option C, glare, yes. Colored halos, no, not in iridodialysis. So option B and C, yeah. So that is about our question. Not EOG, Abid. EOG, see, EOG is, yeah, I think you corrected your answer saying ERG. See, EOG is specific only for the macula, and that also only for RPE. Yes. Yes, your iron causes RPE toxicity. Essentially, it causes both photoreceptor degeneration and RPE toxicity because of the ions that it releases, the ferrous ions that it releases intraocularly. But EOG is a localized thing. It assesses only the macula. But ERG is an overall, generalized retinal degeneration or disorder. It gives an idea about that. So we use ERG, and that also you have to repeat it every 6 months to see if there is any progressive changes. Because see, today the patient has had a trauma, and I see suddenly after 2 years I won't know anything. So every 6 months that ERG should be done, and we need to compare it. Then we'll know if the B wave amplitude is coming down. The B wave amplitude will keep coming down, and at one point the B wave will just vanish. So that is a finding of iron toxicity. Yeah, siderosis bulbi. Yeah, Best disease, because Best disease is a macular disease, no? So that is why we use EOG. So Best disease is particularly localized to the macula. So when you have only a macular problem, yes, EOG will show some changes, and that is also the reason why in Best disease ERG is normal, because ERG you should have a wider problem in the retina, because the summation of your electrical activity of the entire retina, and in Best disease the entire retina is not problematic. So that is why the ERG will still be normal, whereas your EOG will be abnormal. That's a characteristic MCQ that we all teach. One thing that you should know about Best disease, at least these days they ask you a lot of things about your Best or your vitelliform macular dystrophy. But those days there is only one. EOG is abnormal, ERG is normal. That's it. And then they started asking about the autosomal dominant inheritance of Best disease. So now they ask you quite a few. Yeah. All right, guys. Any other questions in orbit and trauma? Do we what topic is tomorrow? I guess tomorrow is refraction. No, refraction. Yeah, squint. Okay, I don't remember. कल का टॉपिक क्या है रे? Guys, take the quiz seriously. Tomorrow you'll have interesting questions. Any questions? Okay, I also said I'll discuss this that I posted on. Okay, where is that image? Okay, did you all see that? Okay, I'll do that as a separate session. I don't have that image right now in hand. Okay, so today I have posted on Instagram a very interesting cornea case actually. It's ASOCT, and in fact, I've also put up the answer to that explaining because it's quite a little difficult, and I thought at least when you have the answer, you'll have more motivation to go and watch it and learn from it. That's a very crisp, okay, 5 seconds you can learn that ASOCT. So the question also is there and the answer also is there side by side in the next post. So go and see that. Now this orbit question, I'm not able to find that clinical case that I had posted yesterday, and many of you had answered very well. So I'll bring that image tomorrow and then we'll discuss that as a different session. Okay. Any other questions? Orbit and trauma. I think you're all look so traumatized with ophthalmology. Because this INICT gave you that acute hydrops question, which nobody expected. But anyway, INICT is like that. You always get one bouncer like that. It was doable if you had, used the images that I've given in the workbook and whatever we've taught here, there, everywhere, probably doable. Okay, chalo, let me take leave if there are no further questions. Nice to see you, Abid. ओके सो आई विल सी यू टुमारो. विकास जी आपने आके गुड इवनिंग बोल दिया, फिर आप कुछ बोला नहीं. Actually, Abhi, the question about acute eye drops was, they said there is a patient with myopic astigmatism. They never said it was a keratoconus patient directly. They said patient with myopic astigmatism presents with a sudden painful decrease in vision and probably even redness, they said. I don't know about the redness part. But definitely you need not have redness there. Sudden painful decrease in vision, and management was done and they gave a picture. Okay, so that picture has a bubble, okay, a bubble in the anterior chamber. And options was, what was the procedure done? DSEC, DALC, intracameral air or gas SF6 and C3R. See, definitely it's not C3R because I've given that image in a workbook. So it's ruled out. Now, DALC procedure, DALC is you'll have to put sutures. Yes. And DSEC, why would you do DSEC for keratoconus? Myopic astigmatism is keratoconus. Yes. And sudden painful decrease in vision in keratoconus, I've taught you. Whenever there is an acute eye drop stage, there can be a painful drop in vision. See, otherwise it is painless blurring of vision, frequent change of glasses, keratoconus. But keratoconus patient, the moment they say there's pain, they've reached this acute eye drops stage. So I've told you that. And we've ruled out C3R because of the image, and I've taught that image also in image-based discussion in the workbook and during every class. And DSEC, DALC has sutures. You have to put sutures to keep it in place. And DSEC, there's no need for DSEC in keratoconus because I've taught you it's either penetrating keratoplasty or DALC. So you rule out that also. So only thing that is left is intracameral air or SF6. Although I've not taught you the management of acute hydros because that was just way beyond the level of questioning. At your level. I mean, your level means you're just a graduate. Okay, you're just an MBBS. But anyway, they asked that. So intracameral, intracameral means within the AC, and there is a air or there's a gas bubble that you can see. So, just, as a teacher now, I can say we could have used some presence of mind and answered. But I know the exam scenario is very tense. So at that point, to rule out and then come to that answer it's a little mind game. But anyway, that was a question, Abid. Yeah, you can rule out because now you're a resident. Okay, you're a resident and we're not sitting in that exam. See, when you're sitting for an INICT exam and you're looking for the rank and then your future career option, all that is going on in your mind, you're in a very tense situation. So probably, ruling out and arriving at the answer. See, now me sitting at home, I'm not seeing any examiner, any exam invigilator around. I'm not seeing other candidates sitting around. So it's, it's a relatively cool environment. So I have all the in my brain, I'm in that space to think and rule out. But just imagine that anxiety when you're seeing everyone, time is ticking off, and then you're thinking, "Arey, वापस जाऊंगी कि what will my parents ask you how you done the exam?" So in all those situations, it was a little difficult. Oh, your second year, Vikash. Oh, acha. Okay, I can definitely guide you. You can always WhatsApp me or just ping me. Okay. My number is there. You can note down my number 9363435748. So you can ping me. There's no bot or there's no assistant replying. Only I will reply. So I can help you out. Okay. So message karna, WhatsApp me. Right, Vikash? पढ़ना है, पहले पढ़ना है, ऑटोमेटिकली पीजी तो क्लियर हो ही जाएगा. ऑल राइट. एनी अदर क्वेश्चंस? यू मोस्ट वेलकम विकास. अच्छा, अच्छा हुआ अबेद आप थे, बढ़िया लगा. Although it was orbit and trauma, but anyway, we just discussed something which was worthwhile. So, regarding that only, I post I think I posted actually 3 posts on Instagram regarding acute eye drops. There was a question where I've actually posted a question on acute eye drops. Then ASOCT का एक क्वेश्चन था एंड ASOCT का एक लर्निंग क्वेश्चन भी. एंड ASOCT में पता नहीं क्या बोला मैंने, ASACT बोल दिया मेरा ACT फाइबर नेट का सोच के पता नहीं क्या बोला. I given a correction in the comments. But anyway, all right guys, see you tomorrow. I hope you know the schedule. All right, bye, good night.